Most dentists were taught how to scroll through a CBCT, but not how to read one. And this is why even experienced clinicians often feel uncertain when looking at 3D images. The volume is there, the data is there, but the confidence often is not. In the last episode, we explored 2D radiography and the principles that help you interpret projections with clarity. Today, we step into the next dimension and unlock the foundations of modern 3D diagnostics. CBCT is not simply a better X-ray. It's a fundamentally different way of seeing the patient. Instead of one projection, now we see structures as they truly are, three-dimensional, contextual, and connected. But here's the reality. Most dentists learned how to adjust brightness and scroll through slices. Very few were taught how to evaluate the volume using a structured, repeatable protocol. And that is exactly what we will build today. Let's start with the basics. A CBCT volume is organized into three orthogonal planes: axial, coronal, and sagittal. Every diagnostic conclusion depends on navigating these planes with purpose rather than random scrolling. There are three additional factors that define what you can and cannot diagnose: the field of view, the voxel size, and the radiation mode. A small field of view provides excellent detail for endodontic or periapical evaluation, but does not show the surrounding anatomical context. A large field of view gives you orientation and overview, but the image becomes less detailed. Before interpreting a case, you must always know whether you are looking at a small or large field of view. Voxel size determines resolution. Small voxels reveal fine details such as fractures, internal resorption, or small cortical defects. Large voxels soften these details and make subtle findings easy to overlook. You can only diagnose what the voxel size allows you to see. Radiation mode also matters. Low-dose scans are excellent for general assessments, but introduce noise and reduce clarity. High-dose scans provide sharper detail, but carry a higher radiation exposure. A clinician must always interpret findings according to the dose mode used and be aware that noise can mimic pathology. With these parameters in mind, we can now focus on the principles of interpretation. The first principle is orientation. Before diagnosing anything, you must confirm where you are in the volume. You verify head position, the mid-sagittal plane, the occlusal plane, and the symmetry between right and left. If orientation is wrong, every structure can appear distorted. The second principle is anatomy before pathology. In 3 dimensions, you evaluate the cortical plates, sinus wall, nasal floor, mandibular canal, incisive canal, bone contours, and root morphology. You build a mental model of what normal anatomy looks like in 3D. The third principle is contextual diagnosis. A real finding must appear in all 3 planes. A radiolucency in axial must also appear in sagittal and coronal. A defect in the cortex must be visible from multiple directions. Real pathology has volume and consistent borders. Artifacts do not. The fourth principle is correlation. CBCT findings must be evaluated together with the clinical exam, probing depth, patient symptoms, intraoral photographs, and 2D radiographs. CBCT does not replace other modalities, it integrates them. Now let's look at the most common errors dentists make when evaluating CBCT volumes. The first error is misinterpreting slice thickness. If the slice is too thick, you lose the fine detail. If it's too thin, structures may appear fragmented. Slice thickness must always match your diagnostic goal. The second error is chasing artifacts. Beam hardening, scatter, patient movement, and metal restorations can all mimic pathology. Recognizing common artifacts helps prevent false positives. The third error is ignoring asymmetry. One of the most powerful diagnostic tools in 3D is comparing the right and the left side. The human body is symmetric, and deviations from that symmetry often indicate an underlying problem. The fourth error is skipping regions. A complete CBCT evaluation requires a systematic review of the entire volume, including the orbit, sinus, nasal cavity, TMJ, alveolar ridge, apical areas, posterior regions, the canal pathway, and incidental findings. Now let me show you how I apply these principles in daily practice using my Axeos CBCT inside Sidexis 4.0. This is the exact workflow I follow for every case. I begin by confirming orientation. In Sidexis, I align the mid-sagittal plane, check the occlusal plane, and verify symmetry. If the patient head is tilted or rotated, the anatomy will appear abnormal even when it's not. Next, I review the volume boundaries. I start in the axial plane and scroll from superior to inferior, examining the sinus, nasal floor, cortical borders, and symmetry between sides. Then I move into the coronal and sagittal planes, ensuring each anatomical structure is consistent across all three views. Once orientation and anatomy are confirmed, I begin my systematic evaluation. I review the paranasal sinus for membrane thickening or septa. I examine the nasal cavity, alveolar bone, apical regions, and cortical plates. I follow the mandibular canal or incisive canal, checking proximity or encroachment. I evaluate bone continuity, root morphology, and the spatial relationship between structures in 3 dimensions. Every suspicious area must appear in all 3 planes. If something appears only in one view, it's most likely an artifact. A real lesion has a defined 3-dimensional shape and consistent density changes. When needed, I adjust slice thickness. For fractures or detailed root evaluation, I reduce slide thickness. For sinus anatomy or broader structures, I use thicker slices for a better overview. Finally, I correlate everything with the 2D radiographs, clinical findings, intraoral photos, probing depth, and patient symptoms. The CBCT becomes one integrated component of a complete diagnostic picture. This is the CBCT workflow of the Devigus method: simple, structured, repeatable, and designed to give you clarity when navigating a 3-dimensional volume. In the next episode, we move from human interpretation to assisted interpretation. We explore how AI systems analyze both 2D and 3D imaging, what they can and cannot do, and how to use AI responsibly to support your diagnostic confidence. If you have any questions about CBCT interpretation or using Sidexis 4.0 in your own workflow, ask in the comments and I will answer with a dedicated video. Welcome to 3D imaging in the Devigus method. Voila!